Welcome, everyone. I'm Dr. Tara Kiran. I'm a family doctor at the St. Michael's Hospital Family Health Team, and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. Our department is really pleased to bring these sessions to you, along with the Ontario College of Family Physicians. And I'm going to turn it over to my colleague, Liz Muggah, who's going to introduce it. I will say that Liz and I today are wearing our matching shirts because, you know, today is all about vaccines once again, and we're getting closer.
Hi, everyone. Thank you so much. So yeah, I'm Liz Muggah, family doctor in Ottawa. Really delighted for all of you to be joining us today. It's going to be a really amazing panel with incredibly inspiring stories, including about delivering vaccines out in the community and using mRNA. And Dr. Allison McGeer joining us as well to give us her expertise. This is an accredited session. Details are there on the slide about that accreditation. Next slide. So I'll just read the land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from unceded territory for the Anishinaabe and Algonquin here. Over to you, Tara.
Thanks, Liz. So I shared these tools developed by the Women's College Hospital Health Equity Committee last time, and I'm resharing because I do want to just speak a little bit further about creating a culturally safe space, of course, for our Indigenous patients, but for all patients who come in. And I know one issue that has been raised is people feeling uncomfortable about people coming in without a health card. Next slide. I will say probably you shouldn't be working at a pop-up clinic if you do feel uncomfortable about serving people without a health card, because these are supposed to be low barrier clinics. But some people felt uncomfortable because of the medical legal issues potentially. And so I wanted to just highlight that the CMPA has now answered this question and made it very clear that the CMPA members will be eligible for assistance when administering vaccines in Canada without regard to whether an individual is a resident or a non-resident of Canada. So you should feel safe and covered around this issue. Next slide. We've been bringing you these sessions now for over a year, and if you want to listen to any of our past sessions, please do go to our website. There are many that are very relevant, including a great one on VITT, which was last time, and we will be posting the recording of this session along with the resources on our website shortly after. Next slide. Thank you to our organizing committee, and thank you to you for all of your input on what you want to hear about. So please, at the end of the session, please fill out the evaluation and tell us, what speaker you want to hear from next time, what topic you want covered. Next slide. So I'm delighted to have people from across Ontario today telling us where they're, about their vaccination stories, so that we can all get ready to hopefully deliver more Moderna in primary care. And of course, happy to also have David and Liz join me as co-hosts. Next slide. So Kiran, I'm going to turn it over to you to just introduce yourself.
Hi, I'm Dr. Kiran Chu. I'm a family physician here in Toronto at the Bridgepoint Family Health Team. I wanted to say from a disclosure point of view, I am the medical director here and also part of the East Toronto Family Practice Network, so I do get honorarium for that, as well as for speaking here today.
Thank you. Nili.
Hi, I'm Dr. Nili Kaplan-Myrth. I'm a family doctor in Ottawa. I have no disclosures to disclose.
And I'm Allison
Allison.
McGeer. Sorry, I'm Allison McGeer. I'm an adult infectious disease physician at Sinai Health System. I do quite a lot of work with different vaccine companies, and you can see my disclosures on the slide. Thank you.
David.
Hi, I'm David Kaplan. I am the Chief of Clinical Quality at Ontario Health and have some responsibilities there for primary care. Family doctor in North York, and I receive an honoraria from the Ontario College of Family Physicians. And I don't have not related to the other Kaplan on the panel today. So I'm just
Wonderful. Liz?
I mentioned who I was, and as president of the Ontario College, I do receive a stipend for that role.
Yeah, and so as mentioned, I'm Tara Kiran, and I do get I do get some salary support for the research I do, as well as have received some grants. The only for-profit company is Gilead Sciences for a grant on hepatitis C. Next slide. So excited that you guys are joining us from all over Ontario, which is amazing. And you guys sent in your questions, and it's through your questions that we've really designed this session. So many of your questions continue to be about delivering vaccine in primary care. And we know Moderna has its own specific challenges, so we're going to speak to that, and as well as speaking about how we can leverage community. And then Allison McGeer is going to answer so many of the vaccine questions I know you have. Next slide. So in terms of how to participate, just a reminder that you need to put your questions into the Q&A. I know some of you have started to put some questions maybe into the chat, but I won't be taking questions from the chat. Please put your questions in the Q&A, and I will prioritize those ones that have the highest thumbs up. So the ones that, if you see another question there that you like, please give it a thumbs up, and it'll go all the way to the top. And then that way I know that that's a question that we need to prioritize. Please also take a look at the answered sections in the Q&A, because Allison and David and Liz, while our other panelists are speaking, are going to continue to type answers to some of those questions, and they may be answered. I should also mention just up front, I know a lot of you have questions about AstraZeneca and the second dose, and so we will provide the information that we have available today, but our understanding is that there is going to be more information announced later today by the government. So just to let you know that we are going to cover that topic. Next slide. So to start off, though, I'm really delighted to turn it over to Dr. Kiran Chu. She's going to tell us more about, how her practice and her team, her network, she works with a wonderful network of doctors in the East End of Toronto, how they've been supporting primary care to use Moderna, and some tips that we have. So Kiran, over to you.
Thank you, Tara, and thanks for having me today. Yes, we've actually been super lucky to have Moderna and Pfizer in our clinic since mid-March. So we've been running clinics, primary care clinics for vaccines since then. I am part of the East Toronto Family Practice Network, which is a brand new network. We started officially sort of in September of 2019, so right before the pandemic, more to work at like system design, stuff in terms of trying to work with our partners. Our partners here in East Toronto, the East Toronto Health Partners include the McGeer Hospital. Sarah Downey has been a big champion of primary care through there. VHA Home Health Care, Woodgreen Social Services, and South Riverdale leading the community health centers as well. Providence is the other, and Unity Health is the other partner, anchor partner. And EastFPN is consisting of over 170 family physicians. There's about 260 in our neighborhood, so we're still reaching out. And we're a big mix. We tend to be more solo and small group practices. There's only 2 FITs in ours, and two CHCs. So that's the complement there. So that's who we are working here in East Toronto. And because of pandemic, we've been able to work really well together at the beginning, and so that's why we were trusted to help roll out with their vaccine plan. Next slide, please. So in East Toronto, we actually didn't get one of the mass Toronto operated clinics. Those you can see on the map. Kiran definitely did their own mass vaccination clinics, which family practice has been pretty important in terms of staffing, and so those are the numbered ones. And the stars are our primary care clinics in East Toronto that have been running various vaccine clinics, either Pfizer, Moderna, and or AstraZeneca. Next slide. So people are asking in particular about Moderna. So Moderna, once it gets to us, it's already been thawed. You can store it in a regular temperature monitored vaccine fridge for up to 30 days. But once you puncture that vial, you have to use all the doses up within 6 hours. It can be stored actually between 2 and 25 degrees once you've punctured it. So after you've drawn up your vial, your syringes, you can either leave them at room temperature as long as it's less than 25 degrees or put them back in the fridge. So the easy thing about Moderna is there's no dilution needed, and it's a 0.5, so it's easier to see than the 0.3 that the Pfizer is. You're not supposed to shake the bottle, you need to swirl it, and it's supposed to kind of have that whitish color, sort of the same as the PDSL or the PDSL. It is drawn up, as I said, 0.5 cc, so it's a little bit easier in terms of seeing that line, and it is given IM. So the question, though, interestingly, is whether or not you're supposed to get 11 doses or 10 doses out of this bottle. Previously, we were supposed to get 11, and my eyes are getting worse, so I have to be really slow and deliberate with it. It's not hard. It's just you can't draw them up as quick as you used to with the flu shots. With the flu shots, there was lots in the vial. It didn't really matter as much to get them all out. Even with AstraZeneca, when we were giving that at the end, we often could get that 11th dose out of the AstraZeneca and even still have a little bit more. So that's the only thing about the Moderna is when you get it, to check in with your PHU to make sure you know you're supposed to get 10 or 11. Word on the street for us here at Toronto Public Health is that we only need to get 10 doses out of that bottle. The biggest, most important thing is when you draw the one bottle, you need to label the expiry time so you know exactly when it finishes. That's the #1 key. So it's different than the AstraZeneca in that, you can put it 48 hours, you can put it back in the fridge. This one you need to draw them all up, I think, and just make sure you have that one section. But again, decision up to you. Next slide. So people have asked in particular about whether or not you can bring Moderna to homebound, and you can. As I said, you have to use it within the 6 hours. So the one thing is when you're driving, you need to kind of have it nestled a little bit so it's not jostling around too much and you don't bump them around. Again, it needs to be between 2 and 25 degrees. So it's up to you in terms of how that gets stored. We had I should have brought a little basket with some Kleenex and stuff to nestle them in when we bring them. And just to say, usually when you're doing your home visit, it's about 30 minutes. I'm sure you can kind of whack it down a little bit shorter, but just to be really mindful of the time. This is a picture of Dr. Pham and her patient who had her 100th birthday and her shot on the same day. So she was pretty happy about that. So again, if it's one person and you're doing them, you just have to be pretty mindful of your route and how long you take when that's out of the bottle. Next slide. So at Bridgepoint, we've been lucky enough to get an admin building, which is actually a decommissioned jail, which not many people are using because they're all working from home. And so we've actually run clinics with our own family docs, but also in conjunction with the solo family doc down the street on Gerard here. So this is Dr. Lin, Dr. Wong, Dr. Su, and Dr. Young. So they are all solo docs. And they came for a half day, bringing their Cantonese and Chinese and Mandarin speaking patients, and we managed to do a language specific clinic for them. So I'm not sure in terms of where you are in the province and the other people down the street, and Nili will definitely talk more about that in terms of her experience. But I think if you're able to help each other out, that would be lovely in that sense too. From lessons learned, it is helpful if you're helping other people to have one of their front staff around so they can actually tell who's who. I mean, back then when we were doing it, it was really strict in terms of criteria. So now that it's opened up, maybe it's not as important in terms of making sure the right people are there in line. So that's a good thing for sure. And I think in terms of the Chinese community, it was really important to have the family docs there because they really wanted their own family physician to immunize them, which kind of speaks to the strength in family practice and how we help our patients make these decisions. Next slide. Others had asked about how to run a clinic if you only have one entrance. There's a really, I think, interesting toolkit that I put up there. CFTC, and I think it was University of Manitoba, I think I could have that wrong, kind of put this together. And so you can actually type in, like I have three spaces in my waiting room. I have 2 offices, and it will actually help you figure out your rate and your flow on that end. And so just some things to think about in terms of when you get the Moderna is like, how are you going to get it? Which fridge are you going to put it stored in? It should be just a regular vaccine fridge. You do need your Covaxon, which you guys have talked about before. And again, just how to operate your clinic in terms of what you need and your numbers and whatnot. Okay, I think that's the end of my slides.
Thanks so much, Kiran. So I think you've really outlined for us how we can, as primary care, deliver Moderna vaccines. I saw a comment in the chat from Alan Brill that, their practice has been routinely doing, their family doctors have been vaccinating in a large area, Soccer City, and routinely getting sort of that 11 doses. And I see it's amazing to see how you've done it in so many different settings. I don't see any questions for you at this time in the chat, or the Q&A. So I'm gonna, but we'll keep an eye on that, and certainly I'm sure there's going to be many. So I think there's lots that we can learn from other practices, and I think we've shared some of the links from Dr. Chu's presentation into the chat. And maybe I'll go now to Nili Kaplan-Myrth, who's going to share, I think her story from Ottawa in terms of what she's done, which is pretty remarkable. So Nili, on to you.
Good morning, everybody. So I want to start off by saying that I'm just one small family doctor in a very small practice. I work in the space that I'm in. I have one staff. I have 1,400 patients. I'm part of a family health group, so we have other colleagues distributed around town, but I'm really just this one person. And so I'm going to tell you a story, and I'm going to make it a little, we have nothing to use tongue depressors for anymore in our office. So I'm going to do a little funny thing for you. So basically, here's the story. I have been lobbying since January, as many of our colleagues have been, for primary care to be able to give vaccines to our patients. And so when in April, we were finally told by our public health unit that family doctors could have vaccine, we quickly ordered it and we reached out to our patients. So the first thing was, you can see this, my staff. So I'm not working on my own. I have this wonderful person, Veronica, and she helped to reach out to public health to say, this is how many doses we want. And then she started phoning patients and I started phoning patients. And unfortunately, before the pandemic, we didn't have everybody's email addresses. So it was a little bit time consuming to contact all of our patients. At that point, it was AstraZeneca. So it was everybody 40 and over. And so we spent some time phoning, and this is my daughter. She was bored with online school, so she took off a week from school and she helped phone our patients. People loved getting calls from a 12-year-old. And then we had to learn how to do COVAX. So COVAX Ontario is not so hard to do, and Ontario MD does have great tutorials, but I had to rely on my husband at 2 o'clock in the morning when my staff and I were like, okay, we need some backup here. He's not a doctor. He has nothing to do with medicine, but we got him registered and also a couple of medical students registered to help us so that we'd be able to do all the paperwork efficiently. Because like I said, small office. We also reached out to politicians. So we had people who came to our office in order to highlight that family doctors should be able to give vaccines to our community. And so that was important because we want this to be something that all family doctors can do. So then what we did is, after booking our own patients, in the first week, we try to fit them in between our regular appointments. So I would book a 15-minute appointment. I would use my waiting room, which wasn't otherwise being used for anything else. I divided it into sort of two, and it was our vaccination station. So we could have one person on one side of the room, another person on the other side of the room, or if they were a couple, they would sit next to each other, and then we could have 4 people in the room at once. And then I also had this examining room where I could have another person or another family. And so I was kind of going back and forth and immunizing people. And then also, if I didn't have somebody in my examining room, I would take that 15 minutes while patients were waiting to, like, after they'd had their vaccines, and I would make my phone calls and do other things. So that first week, it was a little bit hectic, but we were able to see, sometimes I'd fit in 11 people during the day, sometimes up to 44. It was always a multiple of 11 because we always got 11 doses out of a vial. So see, we had all these people who came in. This is a childcare worker. She's not my patient. One of the things that we did, which addresses the criticism that you hear sometimes where people say, well, family doctors, but lots of people don't have a family doctor. So I said, well, heck, I'm happy to immunize people who aren't my patients as a way to reach out to community. So we had a lot of people who came in who weren't our patients, and that meant a little bit of extra work, but it really wasn't that hard to do. And we encouraged people to, you know, this is a nursing mom, and I was very public about it, trying to encourage people to see that that there is no barrier to coming in and getting your vaccine. So that was the first week. We had gone through 220 doses in the first week, just between patients, and it was going so well. I reached out to public health because all of these people were asking me if they could please come and get the vaccine from me. And it was still, you know, the days, it's kind of still true actually, but people couldn't access the vaccine through pharmacies or through public health. So public health sent us another 300 doses, or sorry, another 200 doses. And that's when a patient came up with the idea of Jabapalooza. So that was a name that patient came up with. And so my husband and my staff and I went to work. We borrowed sandwich boards. We asked neighbors to give us chairs. I tweeted that I needed some way to block the street, and immediately 2 city councilors set that up for me. So we had our street in front of my office blocked off for a Saturday, and medical students stepped up. And this was really cool because these medical students had been bored. They weren't getting any clinical opportunities. And it was kind of win-win. Like, they were eager to volunteer during a time when they weren't allowed to do electives, but they were allowed to volunteer. And they got to learn how to draw up syringes. They got to learn how to give needles. They did everything. They did all the roles, and they even got to meet Jagmeet Singh. It was pretty cool. So then this is what happened. And I don't know if you can see it, but basically this is our street set up with chairs all along the block. And patients that day came in our front door. We had the waiting room set up. We immunized them. So they came in the front door unimmunized. They went out the back door immunized. And then medical students brought them to sit in the street. And each medical student went and talked to patients about what to expect in the days and weeks after their vaccine. And we gave them their appointments to come back in August for their booster doses. So it all ran really smoothly. Here's Harry giving a vaccine. Like, these students had never done this before. And by the end of the day, they were all experts. So in that first Jabapalooza, we went through another 220 doses. So by the end of that week, we had given 550 doses. So, you know, we were keeping all the vials, and it was funny because I thought that we were going to have to give them back to public health. It turns out they didn't want them. So I gave them to the Museum of Civilization, or I guess it's the Canadian History Museum, because they're doing a little thing about that. So after that, we decided to do another Jabapalooza because there were so many essential workers who couldn't access the vaccine. So Jabapalooza 2 was a little bit different. Instead of doing it in front of my office, I decided, now this wasn't any of my patients. These were 330 people that we immunized who were just construction workers, grocers, all the people in the community. And because I was very vocal publicly, all of these people volunteered, and they felt like I was doing them a favor by letting them volunteer. So this is the thing, is you don't have to have a large staff. You don't have to be a large institution. All you have to do is say to your community, hey, who wants to help? And we had nurses, and we had paramedics and dentists and others who helped, but also we had just people who had no medical background. So we used a soccer field. I don't know if you can see it there, but the Ottawa 47s is our local soccer team, and they gave us their field, and 2 private business owners donated to give us a 40-foot tent because it was going to be a rainy day. And the Ottawa 47s rounded up from Carleton University and other places, all these other little tents. So we set up in the soccer field all these tents, and under each tent, there were a few chairs, and then there was a table, and on that table, all the things that you'd need to give the vaccine. So we had, you know, the alcohol swabs and everything else. And we had drawn up in the morning, I met the medical students at my office, we had drawn up the first batch of vaccine in my office in the morning, and we put it into a cooler, and we brought that cooler to the soccer field. Halfway through the day, a nurse and some medical students and a dental surgeon went back to my office, and they drew up more vaccine and brought the second doses so that we didn't have to, we would have been able to do it all within the 6 hours, but I was worried. So we did it that way. And then I recruited my sons, and they came and they helped to register people. Now, because they weren't my patients, I needed to have a way to put them into my EMR, because at the end of this, although everybody else was volunteering, like, I'll probably, be able to keep track of everybody in my EMR, as well as everybody's papers in COVAX. So they were scanning in people's health cards as they arrived, and that went right into my EMR. And then everybody had their consent forms, and if they didn't have them, we had some blank ones. And after, people they'd go to the registration thing, then they'd go sit down in the tent, and then a pediatrician in the community and I and the medical students immunized, and then somebody was scribing, writing down which arm and what time, and taking those papers, and we were collecting them and shuttling them back to my office every hour or so. And back at my office, my husband and medical students were sitting there and entering it all into COVAX. So people were getting like their responses from the province straight away. And it was a very rainy day, but nobody was sad, nobody was wet. And this is the whole field here with all the tents. Now, we had booked 30 people per 30 minutes, thinking 1 a minute would be hard to do. It turns out we were ahead of schedule the whole time. So we're going to do a third Jabapalooza, which we just announced for June 5th. And this time we're going to do Moderna. And I've given Moderna in retirement homes. So I know, like my colleague said, like Kiran said, it's really like, it's just a matter, you have to swirl it, and you have to be like a little bit more gentle than you have to be with AstraZeneca, but it's not any more difficult to administer. And so we're going to do the same thing. And the soccer field and all these volunteers, I made an online form for volunteers to register so that I could keep track of them. And we made an online form for people who aren't our patients to register. And then we had a system where we would then send out in batches. We'd say, okay, you're all booked for 9:30. This is when you need to come. Here's your consent form. And the only other little tidbit of information I give you is that although we had 330 people the first time, and so we thought, well, we'll have a few people as backup in case people don't show up. 28 people out of 330 didn't show. So during the day, we kind of reopened registration, and then we ended up bringing more people in. So nothing went to waste. And by having them use this online registration, it was designed so that the only information that went in there went into a spreadsheet that was immediately able to be uploaded to COVAX Ontario. So, and I have all of that. You don't have to follow what I'm saying. I have all of that written down as a blueprint I wrote it in the Medical Post, but there's a link that I think they're going to share with you today that gives you all of the information about the different roles that I designed for volunteers, because that was really important. You have to delegate. So I nominated one of the medical students to be the lead medical student to organize what the medical students were going to do. And I told them, these are the roles I need you to fulfill, but like you do it. And then same thing for volunteers, the community volunteers. We had about 10 medical students. We had about 25 community volunteers, and they were helping with shuttling people from, the line to where they were going to sit, and being scribes and all of those other roles. St. John's ambulance came, and they were there just in case we needed any medical backup, which we didn't. There were all kinds of different roles, but I laid those out in the little blueprint that I can share with you. And really, you don't have to do this. You don't have to do a Jabapalooza. You can just do the thing that I did at the beginning, where you're just doing it in your offices. It's very doable. And it's also a nice way to connect with the community. It's been so nice to reach out and have, like I could stop in the street and speak to a garbage collector and say, hey, look, we're doing this thing. Do you want to come down? And same with the local grocery store. And like everybody really appreciates it. So that is the short and long story, all about Jabapalooza and about how you can do whatever you set your mind to in family medicine. And now we have, I think, a few.
Wow.
You can,
yeah, Nili.
So if you want to show those slides.
I think, yeah, please do. Do you want to speak to this slide, Nili?
Okay, these first photos are in my office. So you can see that this is in my waiting room. I'm giving Jagmeet Singh his shot, and then I'm giving the childcare provider and one of my patients who is a nursing mom, and then Joel Harden, who's our MPP for Ottawa Centre. And then those are two of the medical students who were so important in this whole operation. So that was in that first week and the first Jabapalooza. And then if you go to the second slide, those are photos that are both from on the street at the first Jabapalooza. That's me and the medical students in front of my office. And then in the field, you can see our tents and everything set up for our second Jabapalooza. So that's very much what our next one on June 5th is going to be like, and then we're going to repeat it all in August, because we did book everybody for their booster doses. And one of the services to the community is that nobody has to hunt. And I said to everybody, look, I'm going to give you the next date, and if the government changes when they can be done, if instead of 16 weeks it can be 12 weeks, then we will send out an email to all of you and we'll let you know. So just, if you hear something in the media, don't worry, we're going to reach out to you. Just give us a few minutes and we will. So it's, and like doing this on a scale that we're doing it. I mean, we gave 825 vaccines so far, and we're asking for 400 more Moderna for June. And then we'll do it all again in August and in the fall. So, it's very, just like it makes everybody, what people basically said to me is it was the first time in the pandemic, all these volunteers, that they felt that they could do something where it was celebratory, and it, put the fun into vaccination. So it's pretty cool.
Yeah, so what you've just described, Nili, is pretty cool, pretty amazing. And so we see lots of comments in the chat to that effect. Dr. Nili's story is so amazing, says Teresa Baresi. I love it, a testament to the power of an enthusiastic family physician who really cares. This story needs to be brought forward to Doug Ford's office. People talking about how it's a great community event and a great example of community participation and effort. And I think that really stands out. We haven't been great at using actually our volunteer resources in general in this pandemic compared to some other countries. I think we had Trish Greenhall from the UK earlier, and in the UK they have actually used tons of volunteers, and we haven't as much. So really great to kind of see that in action. Others people saying, this is a great story, Nili. We're gonna, our office will certainly be using your tips, Rosemary Lowell says, as we launch Moderna this coming week. Incredible, incredible, inspiring work, Nili and Kiran. So, I think people are just blown away by both of you and what you've been doing. People also love the puppet show, by the way. and so I'm just going to maybe take a couple of questions here, because I'm going to go back, I think, to Kiran, actually, because Kiran, I think as Nili was speaking, there were a couple of questions that came up for you, and I just wonder if you could speak to it. One is just sort of about language, cultural and language needs of patients, and whether PHUs are meeting them and how your team met them. And another is, I guess, about the fridge and storage issues around Moderna and the fridge.
Yeah, so about the language part, it seems that it comes more from organizations sort of advocating for them and talking to different people. I could be wrong, that's just my experience here in Toronto. I know that for us, it's sort of been from a grassroots point of view. In Toronto, we're in the East End, we're really lucky to work with the neighborhood organization. I think I put it in the Q&A just now. And they actually have resources translated into multiple languages there. So it's on the website so people can download that. For the consent form in particular, I know that I have the one in Chinese, and I'll be honest, I'm not sure how we got that. Someone emailed that to me. So I'm not sure where on the web you can access that. So yeah, I think for us, it was just a recognition as well, just of where I physically am in Toronto, that we wanted to support the other physicians that didn't have a team around them. And so when we reached out, that just seemed like a natural fit in terms just from geography and what the patient needs were on that end. And then Tara, I think the other question was about the temperature vaccine monitoring part. So yeah, I think each public health unit probably has a little bit, depends on what they're saying in particular. Here in Toronto, they do want you to have, if you can, that data logged, like the continuous monitoring one. I'll be honest, I can't say for sure 100% that you have to have that. I know they definitely want your fridge to have passed inspection in the last little bit, so that definitely is there. When we got the form to sign up, it actually has everything written on that, and I'll be honest, I didn't look that up before this talk, so I can just tell you off the top of my head, so I triple check everything I have to say. But yeah, I know that some of them want that continuous data log one. The other one that we definitely have is just the one where it looks like a vial of vaccine that's sitting in the fridge and it's externally monitored on that end.
Yeah, thank you so much, Kiran. And I think, as I was saying, that your group has really done an amazing job pulling in small practices to work collaboratively, which is an inspiring example, I think, for others, and completely agree. If you guys have comments that you want to make to Kiran or Nili, please put them in the chat. If there are questions to our panelists that you want us to answer, put them in the Q&A. I'll just say, Alan Grill has been sharing another fun story about a soccer city kind of drive-through in York Region organized by Pearl Yang and her Stouffville Medical Group as another fun example of family doctors sort of punching above their weight and making impact into the community. And David, you mentioned, about the power of volunteers in the Toronto Public Library clinics that you're going to be doing where the staff have volunteered their time. I think if you look at the comments, Kiran and Nili, you'll see that people are just blown away by your story. So thank you so much for sharing. I'm going to actually do switch gears a little bit and do a little bit of more Q&A related to the vaccines now. And I think the first thing I'm going to start with is just around, vaccines in kids in the age group 12 to 16. Of course, that's something new that's happened since the last time we all gathered. And Allison, I know you put something in the Q&A already, but I wonder if you could speak to this. So Elena Dorobantu asked, what is the safety profile for children over 12 regarding the Pfizer vaccine? Are there expected short-term and long-term side effects? And I wonder, Allison, if you could speak to that.
Yeah, sure. So there are a bunch of places where you can see the summary. I put the link to the new NACI statement, which has just like 3 paragraphs of description of how big the study was and what the effect size was. But the fundamental short-term answer is that it looks like it's as effective as it is in adults, which is what people were expecting. It's a little bit more reactogenic in kids, right? Your immune system peaks when you're like 8 and it's downhill all the way after that. So adolescents tend to get more local side effects like pain and fever than us older adults do. But otherwise, absolutely nothing unexpected. And remember, we get back to there's never been a vaccine with long-term adverse events any more than there's been an antibiotic with long-term adverse events. You get the vaccine, it's in your body for a day or 2, it's gone. Of course, this is a new platform, right? So anytime we're using a new platform, just like we're using a new class of antibiotics, we're going to be a little bit more worried that there might be something unexpected. So it's completely natural that people are anxious about it. But mRNA vaccines have been in development for 20 years. People have looked at them very carefully. They've been approved for use precisely because there's nothing that people can find that means you need to worry about them. So anxiety normal, not everybody's going to choose to get their adolescent vaccinated, that's fine. But nothing in there to say that we need to be worried about that. Kids under 12, the studies are running now. So we're going to have to wait for the results of those studies before we move to kids under 12. It's also true, some really interesting data from Israel that hasn't been published yet that suggests that with all of their adults vaccinated, okay, so they're greater than 90% of all their adults with 2 doses of an mRNA vaccine, and they are not seeing disease in kids. And so our current thinking is that we're probably going to want to vaccinate kids, in part because they do get immune system disease. It's COVID is not completely trivial in kids. But we may not need to. So we just all need to be kind of sitting tight about what we're going to do about under 12s until things evolve a bit further.
Thanks, Allison. So just a reminder, I think people asked, what is the hard cutoff for Moderna for age groups? And I think Alan Grill just put in the chat that one must be 18 to receive Moderna, not 17 plus, 18. And for Pfizer, it's 12, not 11 plus. So just to emphasize that. And then I think there was a really good question, and David Kaplan, I think you were going to answer this one live. So Cheryl's asked, I am uncomfortable with immunizing 12 to 15-year-olds without parental consent. What is our coverage? So, I think this brings up a really great issue. It's an issue we have in family medicine more broadly, right. One that we're not unfamiliar with. But what do you?
So I won't speak. Maybe I'll chat as a ethicist, so I trained as a bioethicist before I did medicine. So I think there's a misunderstanding among the public, mostly among probably parents, that there's some sort of magical age of consent in the province of Ontario. So the consent and capacity legislation in Ontario requires that we can do any sort of medical act, but we need to get informed consent, and that requires that a patient has the ability to understand and appreciate. So those are two different things. Understand and appreciate the decision, and by appreciate, it means that they understand the reason or what could happen if they do the medical intervention, in this case, the vaccination, or if they don't. And if they're able to understand and appreciate, meaning I want to get this vaccine, I understand that it's safe, I understand if I don't get the vaccine, that I could get COVID, and that COVID could have, I know what that means to get COVID, and the reverse is true. I would feel comfortable vaccinating a 13-year-old without some sort of written parental consent, because I think that I've been able to establish that that person is mature enough to give informed consent. So I think it's going to be very dependent on people's comfort, because it ultimately, each of us as clinicians needs to feel that we can get true informed consent from somebody. So there isn't going to be a document that's going to make us feel better. We have a duty every time we offer a medical intervention to get informed consent.
Thanks so much, David, for clarifying that. I'm just going to, draw people's attention to the chat if you haven't looked there. Thank you to our colleagues Tim Lee, Vanessa Reddit, and Harry O'Halloran, who have shared some language and cultural specific resources that you can use in your COVID vaccine clinics if you haven't had a chance. I will also say that our own clinics that I've worked at use the language line as a great source for translating. And so it's very cheap, it's easy to use. So that's another great option for if you're doing, if you're doing working with a larger organization on a pop-up clinic to try and coordinate that. But I am going to turn it over now to Allison McGeer, because I know a lot of you have questions about second dose and AstraZeneca. That's the hot topic right now. I think Allison's going to go over some of the evidence, but maybe before actually Allison presents her slides, maybe I'll turn it over to David or Liz. Can one of you just speak to kind of what's going to be coming later today? David, it sounds like you can do that.
Yeah, sure. So later today, in about, I guess, an hour and 15 minutes, there'll be a press conference from the ministry talking about their plans for AstraZeneca for the remaining doses. There are tens of thousands of AstraZeneca doses that are in the province. Some of them are sitting in our own fridges as family physicians and nurse practitioners. Some of them are back at public health units, and some of them are actually back at the government, depending on what people did with their doses at the pause. I think there's a number of medical issues, scientific issues, logistical issues, especially if the doses are no longer in people's practices. And it'll be interesting, but very soon we'll all find out what the plan is in Ontario. Again, I think we all need to realize that each of us feels that, even if we're told we could offer AstraZeneca, it's up to every individual clinician to feel comfortable doing that. And getting informed consent. And if you don't feel that you can get informed consent based on the data, or you feel uncomfortable, no one could really tell you that you have to use those doses that you have in your fridge, for instance. So let's wait to hear what the government says very soon. But I just want to remind people that you can help your patient find a clinic if there is one available, and the government says it's okay to get an AstraZeneca vaccine, but you don't have to do it yourself.
Yeah, thank you, David. So we're waiting with bated breath to see what kind of the direction is coming. In the meantime, though, I think we can still educate ourselves about some issues like what the evidence is currently around mixing and matching, what the evidence is around VITT for if we did give AstraZeneca for the second dose, and what the evidence is around dosing interval for AstraZeneca. So I wonder, Allison, if you're able to enlighten us a little bit about some of those issues, and I'll turn it over to you. And Nina, if you could start Allison's slides.
Okay, I can try. So I made a list on this slide of what I think the issues are for people deciding whether they're going to get second dose AstraZeneca versus mRNA vaccines, recognizing that, you know, it's possible that the government's going to make a decision for us in the next, you know, hour and a quarter, but it's still probably worth thinking about. So for some people, it's about the local effects immediately after the vaccine. I think particularly for younger people, whether there's a difference if you get second dose mRNA versus AZ. Obviously, people want to know about immunogenicity, what's happening if you mix doses and whether you'll get a better response to one vaccine or the other. A big question about the risk of VIT with second dose AZ. You're thinking about it, you need to know what your risk of COVID is going to be over the next 2 months, what's going to happen in the community, in the risk. Need to think about what the delay is going to be between AstraZeneca and mRNA. And then I think there are a couple of other issues that are individual level, okay? Lots of people who've been talking to me about whether they're going to get second dose AZ have been saying, well, you know, if I use a dose of AZ, then that frees up a dose of mRNA that we might send to India or somewhere else that needs it. So I think there's lots of people with feelings about the fact that they want to be being a good citizen and doing the right thing, even if it maybe involves some risk to themselves. And then there's always the issue when you're talking to people about, you know, how we judge low risk, high consequence events, because that's the real challenge with VIT, is that it's a really small number, but it has really significant consequences if it happens to you, and figuring out how to think about that is hard. So let's talk first about the current risk of VIT with the second dose of AstraZeneca. The only place in the world where there are significant numbers of second dose AstraZeneca vaccines being used at the moment is the United Kingdom. The United Kingdom, 3 days ago, that risk was quoted as 1 in a million. Okay, they had 8 episodes of VIT after second dose AZ. Yesterday, it went up to 1 in 600,000. They're now up to 15. Today, it's down to 1 in 500,000. So what's happening in the UK at the moment is that the people, we're just starting to see the cases. The issue with getting a number for VIT is that you think about the timeline, you get your vaccine. The symptoms start on average 5 to 10 days later. So let's take 7 days. But symptoms usually start as non-specific. So it takes on average another week before somebody starts the testing process. It then takes another 3 or 4 days to confirm it. It's a hard diagnosis to confirm. It then gets reported to public health. Public health has to confirm it. Somebody's got to go through the criteria. There's a back and forth. It's got to move through the levels of public health. So it's taking most jurisdictions 6 or 7 weeks from the date of vaccination to get the report in and cleared and to know it's a case of VIT and to add it to the system. So what's going to happen is over the next month or 2, we're going to accumulate data on second dose VIT risk in the United Kingdom. And that's critical for those people who are going to get doses. I think it's going to rise significantly, but I don't think there's any way of judging at the moment whether that increase is going to be to 1 in 1,000 or 1 in 50,000 or 1 in 25,000. We're just going to have to wait to see what happens with it. We do have some data. Now, am I moving slides or are you? Sorry. Next slide. We do have some data on reactogenicity and immunogenicity of an mRNA vaccine after AstraZeneca. Okay, it's 2 studies running. I'm sorry, clearly I was having trouble with my fonts last night when I was making these slides. So the first of them is called COMCOV from the United Kingdom. It's a randomized controlled trial, single-blinded, with all possible combinations of first dose, second dose with AstraZeneca and Pfizer, with 2 time periods, 28 and 84 days between dose 1 and dose 2 for people who are over 50. What's been published so far from this study is the reactogenicity in the group that got revaccinated at 28 days, which we'll talk about in a moment, I'm told that there's immunogenicity from those people and that the immunogenicity looks fine, but that's just, you know, reliable observer within the government, okay, via Allison, still hasn't been published anywhere. The CombiVac study is, you know, science by press conference at the moment, okay? They had a press conference a couple of days ago and released some of their results. So this is a kind of a weird randomized controlled trial. So it's open label, and the randomization is after you got AstraZeneca, and if you were more than 8 weeks out, they didn't specify the exact time frame, you got randomized to either Pfizer or to no second dose temporarily. And what they said was that the numbers that they quoted were that only 1.7% of people had reactogenicity so severe that it made them stop their activities of daily living for a day or two, and that the immunogenicity with Pfizer vaccine was the boost that you would expect after a second dose of any vaccine. So hopefully both of these studies will get us more data shortly. Let's just look at reactogenicity for a moment, because there's been a bunch of discussion about this. So this is the figure from the Lancet paper, again, 28 days, second dose. CHAD is the UK abbreviation for the AstraZeneca vaccine, BNT is the Pfizer. So you can see from this slide that if with either mixed schedule, you get more adverse events when you mix than when you don't mix. Here, the yellow bar is, it was mild enough that it didn't interfere with activities of daily living. The light, whatever it is, pink, orange, red, is it interfered but didn't stop activities of daily living. And the red bar is, I just couldn't do stuff because of the symptom on that day. All of this is short-term, immediate post-vaccine. But what you need to know, next slide. So the first thing to recognize is that there's an oddity to the mRNA and AstraZeneca vaccine. The reactogenicity with AstraZeneca is greater with the first dose than the second dose. The reactogenicity with Pfizer and Moderna is reversed. It's greater with the second dose than the first dose. So this is now on the top, you can see the first dose, and you can see that the AstraZeneca vaccine is more reactogenic than the Pfizer vaccine for first dose. So to me, the relevant comparison for people who had AstraZeneca first dose is if I get Pfizer as second dose. If you get AstraZeneca as second dose, it's going to be less reactogenic, okay? It will be better. What happens if you get Pfizer for second dose? And that's on the next slide. And so I just cut and pasted the reported reactogenicity with first dose AstraZeneca and with second dose Pfizer after the first dose was AstraZeneca to make a picture in this slide. And what you can see is that, yes, that if you get Pfizer after AstraZeneca, and this is probably what's going to happen for Moderna because Moderna is the same, but not tested, right? If you get Pfizer after you've had a dose of AstraZeneca, you will get more reactogenicity with the second dose, okay? It doesn't look dramatic. Most of it is probably not statistically significant, except maybe fatigue and myalgia, but it's likely to be a little bit worse. Next slide. Okay, so now the question is about, you know, how you balance risks with AZ versus mRNA and what we know. And the short answer to this question is that there's so many uncertainties. It's really hard to know what the level of risk is. So nobody so far has done the kind of model that NACI did for first dose AZ. I'm really hoping that NACI is going to produce that modeling for second dose. So this is my relative back of the envelope calculations, thinking about a second dose fit risk of either 1 in 500,000 or 1 in 50,000, using COVID rates in Ontario at the moment as what's expected over the next month, assuming that if you get your second dose AstraZeneca vaccine, you will get it 4 weeks before you would get your mRNA vaccine. and assuming that your second dose provides you with an extra 60 or 70% protection, which is what we think it does, of the vaccine. And then if you look at the bottom, now you're looking at rates per 100,000. You can see, and the difficulty with thinking about VIT and COVID is that, death is, death, and that's probably an even thing. But if you go to the ICU with COVID, you're almost certainly going to recover, and probably quite completely. If you go to the ICU with VIT, there's a very good chance that you will have significant disability going forward. So the balancing is somewhere between ICU and death, if you're thinking about adverse events. And so what you can see from these numbers is that there are some conditions in which getting the AstraZeneca as second dose is going to put you at less risk of dying or of consequences of being in the ICU than if you leave yourself exposed to COVID. And there are some circumstances where getting the AstraZeneca vaccine might put you at somewhat higher risk of having serious consequences. And so this is the challenge of what people are trying to decide to, how to think about second dose AZ and VIT. It's because we just don't have enough information, and that's nobody's fault, okay? It's called the pandemic. There's not enough information about the relative consequences to be sure about what the balance is about the risk of serious adverse events from COVID versus from VIT, if you choose to get second dose AZ or an mRNA vaccine after you've had first dose AZ. Okay, so now we're off first dose and second dose. Just a quick comment about variants. And my really short answer to variants is that for those of us who are in Ontario at the moment, not on the top of the list of concerns, we just need to get vaccine into people's arms, okay? But a little bit of stuff that's going on. So Ontario at the moment is pretty much everything is B117. We're running about 10% P1 or B351. That number does not appear to be changing, which is nice, okay? Because vaccines are more effective against B.1.1.7. We don't completely understand what's happening in different areas of the world. So in British Columbia, for instance, P1 is about 40% of cases, and B117 is 60. So there are places in the world where P1 is competing reasonably successfully with B117, but it's not happening everywhere. It's not happening in Ontario. And B617, which is that should be B617.2, okay, which is the bad one apparently. We're still really short of information. There was a good question in the chat about, whether the presentation is different, whether the diagnosis is harder, whether there's something else going on. And the answer is nothing from the UK yet that suggests there's any problem with diagnosis or any difference in the level of disease, but it is really early days. The only good news for Ontario is that we still have only a very small number of cases. So the chances that any of us will have to deal with it in the next 2 months is very low. What's going to happen after that? Still somewhat unpredictable. Thanks, Tara.
Thanks, Allison. That was an amazing summary of the evidence that we have at hand, and a really great walkthrough of some of the things that we need to consider when we are counseling patients and people are making a decision, if we get to the place that there's an informed decision-making direction from the government. Maybe I'll just ask you, I know we're short on time, but I just want to ask a couple of follow-up questions. One was, I may have missed this. Did you speak about the dosing interval and the, whether 10 or 12 or, 16 weeks, what the evidence is around if it's given earlier, is that a big deal?
Yeah, so the general rule with vaccines is that if you leave a longer interval and between first dose and second dose, you will get a better immune response. And we're seeing that. The problem is we don't have any, we haven't been systematically testing what happens at 4 weeks, 6 weeks, 8 weeks, 10 weeks, 12 weeks, okay? So we can tell you from the AZ trial, some of the people got it at 4 weeks and some of the people got it at 8 weeks, and the immunogenicity was somewhat better at 8 weeks than 4 weeks. Whether that translates to better protection, still an open argument, okay, right? That's another issue. I can tell you immunogenicity data, but I can't tell you at the moment how well that correlates with actual protection. So I think the evidence is pretty good that 8 or 12 weeks gives you higher immunogenicity than 4 weeks. Does not mean that you shouldn't stick with 4 weeks if you have the opportunity to give people vaccines with a 4-week space. Does not mean that we haven't tested right. At 12 or 16 weeks, it might actually be a little better than 8 weeks. It's not going to be worse. So my take on it at the moment is that 8 weeks is probably a good number to start with. Now, especially now that COVID is going down, there's not as much pressure to get second dose vaccines into people to get the extra piece of protection. But it is going to be, it's kind of interesting. I think if you'd asked any of us who spend a lot of time on vaccines, if we were going to be fussed about 8 or 10 or 12 weeks, we'd have laughed at you ahead of time. So it's a bit odd to actually be having this discussion at all. But fundamentally, I think that a second dose at any time from 4 weeks to, whenever people end up getting their second dose is just fine. Okay, so if you get the opportunity at 5 weeks or 6 weeks or 7 weeks, just go for it.
Thanks so much, Allison. Thank you to all our panelists today. I think, our first two really inspired us around what family medicine can deliver. And Allison, you've answered so many of our questions and tried to help us make sense of a really confusing world of vaccine evidence and policy. Mina, can you just go back one slide for me? I just want to make sure people know as well that, we have done a big update on our COVID vaccine e-modules. So if you haven't already, please check them out. They include some of the videos of Allison and Manika Pai and others from our COVID community of practice, and all updated information, and we'll be continuing to update them based, for example, on what happens in the press conference today. So please check them out if you haven't. Next slide. Our panelists have done a fantastic job, not just answering questions live, but also in the Q&A box. And so we'll be curating those and be able to send those off to you. It may be after the long weekend this time, but we'll do our best to put that on our website and send those Q&A curated pieces to you, along with some of the resources that have been put into the chat. So again, a huge thanks to our amazing panelists today, and thank you to all of you for all the work you're doing. This is our shot, and we're getting it.